Let me welcome you back again for the last session number 10. It's actually a research session assessment. وبعدين we'll see 5 presentation. The winner 1, 2, and 3, 5, 3, and 2, 1,000 reals. But before we start the session, let me introduce the chairman, Professor Khalid Al-Faleh, senior consultant neonatologist. كان معانا بالشرد هو one of the staff of King Saud University Medical City. And now he is with Al Habib Group as a senior professor of neonatology. Second co-chairman, Professor Saad Saadi, and everybody know him. He is the president of the Saudi Neonatology Society for quite long times. وأنا جيت بعده وأستاذ في جامعة الملك عبد العزيز. Before we start our research, we have leftover presentation by Dr. Abbas Ramran for neonatal jaundice, so he will take short times. And then we start our research session. تفضل يا دكتور عباس. You will tell us.
15 minutes. 20? 15.
Take 18 minutes.
18 واحدة ونص. يلا.
Bismillah ar-Rahman ar-Rahim. This is a deferred lecture, not deferred clumping of the umbilicus. Anyway, back to jaundice, but from a different angle. This is a very rare case that we encountered around 1 year ago. This baby was born at 36 weeks by spontaneous vaginal delivery, low birth weight with good Apgar scores, to a 28 primi gravida mom having hypothyroidism. She had ruptured her membrane 31 hours prior to delivery, but she received adequate antibiotic prophylaxis, and she had a full course of dexamethasone, and her CBC, mother CBC, was normal. The baby's assessment initially was normal. He went to nursery to monitor her blood sugar, and her initial CBC was showing normal parameters, including the platelets of 441 thousandths per unit per liter. The blood group of both baby and mama were O positive, and suddenly at around 10 hours of age, the baby was jaundice, and the transcutaneous bilirubin was 185. The baby was admitted to the NICU right away, and his serum bilirubin actually came up to 220. So the baby was started on intensive phototherapy. Her physical examination was unremarkable apart from the deep jaundice. There were no petechiae. Because of the feeding was slow, according to the nurses, we started also antibiotics, taking the history into consideration. If you look in here, and this is the true photocopy of the bilirubin chart of the baby, the one on the left side, you can see the first bilirubin transcutaneous was high above the phototherapy level, as well as the serum bilirubin was increasing in the first 12 hours. But it is below the exchange level, as it is indicated on the other picture. The G6PD assay was normal. Came the next day. The morphology of the RBC morphology was reported benign. It did not help us in the diagnosis, and the direct comp test was negative. But the CBC that we did with the serum bilirubin showed thrombocytopenia. The platelets were 21 only. And we consulted the hematologist, and he suggested to start IV immunoglobulin, keeping in mind alloimmune thrombocytopenia. We needed to insert a UVC for this baby for IV access, and we gave the IV immunoglobulin at 50 hours. But the platelets further came down to 13 thousandths. So the hematologist suggested to add steroids, but we gave platelets at 58 hours, and we needed to give also packed RBC transfusion because the hemoglobin dropped down to 8.5 gram. So there's jaundice and hemolysis and thrombocytopenia. This was the picture of the RBC morphology, and this was reported by our lab as non-specific changes. They did not give us any clue for the diagnosis. But fortunately, our hematologist was questioning their results, so he took the sample, he sent it to hematopathologist who diagnosed this as microangiopathic hemolytic anemia. As you see in here, there are many fragmented RBCs, hemlet cells, schizocytes, and very few platelets if seen. So making altogether a case of severe early neonatal indirect hyperbilirubinemia together with severe thrombocytopenia and hemolytic anemia, this could be microangiopathic hemolytic disease. And if it is very early congenital like this, our hematologist suggested that this is a case of congenital thrombotic thrombocytopenia, thrombocytopenic purpura. To make this diagnosis of congenital TTP, you have to do Adams 13 level in the serum. So we send this and we started treatment right away. The treatment is to give fresh frozen plasma. So the baby was transfused initially on 78 hours of age, given 2 more doses, and look at the results in here. As you see, this is the serum bilirubin. We started at 11 hours of serum bilirubin of 220, and with intensive phototherapy, it decreased gradually. But when we started FFP transfusion, the serum bilirubin never went up more than around 100 micromole. So the baby responded to the treatment. And this is the hemoglobin level. The hemoglobin was dropping steadily. We gave blood, it raised, and then never went down again after FFP transfusion. The platelet count, as it is shown in here, we started the baby's platelets with 411,000, dropped to 21 when the baby was admitted to the NICU. And then actually we questioned the reading, but we repeated soon. And as you see, it came to 13. We gave 1 dose of IV immunoglobulin for the possibility of alloimmune, but it didn't help actually, and the platelets, we gave platelets transfusion. And then when we made the diagnosis of, or we suspected congenital thrombotic thrombocytopenic purpura, we started the FFP transfusion, and the platelet went up gradually to 200 plus at day 6, and then at day 13 it was 900. This is to show, because these babies are prone to develop kidney and brain problems. We did renal function follow-up, and it was normal, together with direct hyperbilirubinemia. It was raised at one stage, but went back. There was some evidence of hemolysis. The retics went up to 7, and the LDH was high, but with the treatment, it came down. We investigated the baby fully. Her electrolytes were normal, serum albumin, liver function, G6PD was normal, PT and PTT were normal, blood culture was sterile, and the hemoglobin electrophoresis was normal. We did also cranial ultrasound looking for hemorrhage. We did it twice, and it was normal. And later we got the results of the serum Adams 13, which if you want to open it, it's a long name, but I think just keep it in mind, Adams 13. Adams 13 activity was, as it is seen here in the underlined red line, the level was very low, 0.09 international unit per ml, and the normal at least should be 0.4. To differentiate it from acquired, where they have antibodies to Adams 13, we did also the antibodies, but it was normal. It was negative. So the baby was discharged on day 8 in good condition. The jaundice was minimum, and he was seen 3 times at the OBD in the first month, and he received FFP at day 13 and day 30. So I'll give you some information about the congenital, or it's called hereditary thrombotic thrombocytopenia. It's also known as Upshaw-Chalman syndrome, and it has the OMM number of 274150. It's a very rare autosomal recessive disorder, and it's caused by the mutations that results in the absence or severe deficiency of ADAMS 13. ADAMS 13 is required to cleavage the von Willebrand factor multimers. And if you have decreased activity with an increased size of von Willebrand disease, this increases the risk of microvascular thrombosis and anemia. The gene was mapped as at the long arm of chromosome 9. And the disease is usually characterized by episodes of microangiopathic hemolytic anemia, together with small vessel platelet thrombi and severe thrombocytopenia, and later on with organ damage, particularly the brain and kidneys. The initial disease manifests in the neonatal period usually, but could pass into adulthood without notice if the baby didn't have symptoms. And if not treated promptly, the mortality rate is very high. It was first reported in 1975 when 3 of 4 affected children in one family died. The exacerbation with pregnancy was recognized in 1976. Pregnant women could have exacerbation, and in 1977 it was recognized that FFP was an effective treatment. In 1998, the severe deficiency of plasma ADAMS 13 was recognized as an etiology, and in 2001, the mutation for ADAMS 13 were identified. And the first large series was reported in 2011. This is a very recent review article on all cases reported between 2001 and 2020, over 20 years. There were 220 cases from 96 reports. The age of diagnosis was reported in 220, 117 were females and 85 were males. The disease is more in females because it occurs more during pregnancy, apart from the neonatal period. But 83 patients of these had severe neonatal jaundice, and HTTP was suspected and effectively treated on only 3 patients. So this disease is unknown. Of the 217 patients who survived infancy, 1/3 of them had major morbidities that occurred at a median age of 21 years, including stroke or transient ischemic attacks, or kidney injury requiring dialysis, or what is now called renal replacement therapy, or cardiac injury, including myocardial infarction, congestive heart failure, or cardiomyopathy. So all major morbidities. 62 patients had stroke. 13 of them occurred during the first 10 years, so it's a disease of childhood. Of the 54 patients who survived their initial major morbidity and were subsequently observed, 37, 2/3 of them, had sustained a subsequent major morbidity. And those who lived 40 years or more, half of them had experienced major morbidities. The FFP prophylaxis was initiated in 44 patients on this series, and 1/3 of them had major morbidity reoccurred even after or on prophylaxis. So the pathogenesis, the disease is caused by severe deficiency of ADAMS13, which could be either acquired or hereditary, and we are concerned here about the hereditary one due to mutations. And ADAMS13 is required for the proteolysis of Van Willebrand factor following its secretion by the endothelium. In this picture, simply, this is the ADAMS13 on the pointer, and these are the platelets, and this is ADAMS13, and this is the von Willebrand factor. You see, it is coiling, and the platelets are away, but and then it cleaved. This von Willebrand factor is cleaved by the ADAMS13, and then they recoil again and goes into the small vessels and distributed. But if you look in this picture, we don't have the ADAMS13, the red triangles here. So the von Willebrand factor, they are very long. They call it extra large von Willebrand factors. And when they go into a small vessels, they form a clot. And because of the rapid and high speed blood flow, the RBCs are destroyed. So that's the name comes microangiopathic hemolytic anemia. So far there are more than 200 mutations reported, and the prevalence of HTTP is 1 patient per 1 million people. The common mutation in North America and Europe is PR1060W. But according to a Norwegian study, this mutation is reported much more than the cases. So many cases probably are missed. This is the picture shown in here, showing the microangiopathic picture. And you need to screen the family for this disease if you have an index case. The clinical course is unpredictable, and clinical discrepancy between siblings of the same, carrying the same mutation are different, and children may be asymptomatic for years. The cause of exacerbation also is not known, but babies, they can present at birth, or they can be asymptomatic. And also there is another period of time when pregnant women also, they are at risk of developing manifestation. In Japan, hemolytic neonatal jaundice was documented in all 43 patients with the disease. 18 infants underwent exchange transfusion, and in Norway 20 patients had the disease, and 9 of them underwent exchange transfusion, but none of these patients were diagnosed as HTTP at the time of exchange blood transfusion. So I think we are lucky we diagnosed the baby early. Acute neonatal episodes could be fatal.
Dr. Abdas, 2 minutes, please.
Sure, inshallah. Newborn who had presented with severe hyperbilirubinemia and anemia and severe thrombocytopenia died at 34 hours without exchange and without FFP, and later was diagnosed. So this case and similar cases make you have to have high index of suspicions to treat this baby simply with FFP. The neonatal period is high risk for developing the manifestation for some reason. I don't have time to mention it. The management usually is FFP, and it's given 10 to 15 milligram over several days, and then baby should be put on prophylaxis like every 2 weeks. Once you start the prophylaxis, it should continue forever, but currently the FFP prophylaxis is not considered for asymptomatic patients, even when they have mild thrombocytopenia, but this can carry the risk of developing problems later on, like cognitive impairment. Now the future management, the potential efficiency of recombinant ADAMS13 has been documented in initial clinical trials, and recombinant ADAMS13 has the potential to revolutionize the management simply because simple self-parent administration, and it's given as 5 ml every 2 to 3 weeks. So in conclusion, HTTP is a rare disorder caused by severe ADAMS13 deficiency. It is commonly misdiagnosed or lately diagnosed. Major morbidities and death are at young age, common at young age. Replacement of ADAMS13 can prevent morbidities and mortalities. FFP prophylaxis currently is the treatment and the prophylaxis, but it's insufficient because still patients are developing morbidities. Use of recombinant ADAMS13 will be simple and safer and more effective. Take home message: when you have severe neonatal jaundice associated with severe thrombocytopenia and microangiopathic hemolytic anemia, think of HTTP, and simple FFP is life-saving management. That's it. Assalamu alaikum.
Thank you so much, Dr. Abbas. We will open the floor for 2 questions only in order to proceed to the abstract presentations. Everyone was satisfied with the presentation, I guess. Has anyone seen a case like this before? We're younger than you, I don't think. Thank you so much, Dr. Abbas. We will proceed with the last session of this meeting. Start. Thank you so much. يعطيك العافية.
We'll start our research session, and it's my pleasure to introduce Dr. Saad Al-Marri, who is a second-year fellow, a neonatal fellow in King Abdulaziz University Hospital. He's going to talk about the effect of booking status on the outcome of infant between 28 to 32 weeks gestation admitted to the NICU.
If you allow me, Dr. Saad, Prof. Saad, we'll just mention some housekeeping messages with regard to this abstract presentation session. There will be few abstracts to be presented. We will allow the presenter to have 10 minutes of presentation, and we will allow 1 or 2 brief questions in order to proceed to the next presentation. The Saudi Neonatology Society is hosting this award. It is an annual award. There will be 3 prizes presented to 3 best presentations. The first one will be awarded 5,000 riyal, the second one will be 3,000 riyal, and the third one will be 2,000 riyal. So we will proceed, and we will announce the results at the end of these presentations. Welcome, Dr. Saad.
Yes, Assalamu alaikum. I'm Dr. Saad Al-Marri, an ICU fellow from King Abdulaziz University Hospital. First of all, I want to thank organizing committee to let me chance to present my study. During our practice, we saw many cases of preterm same age and same gestational age and weight, but has a different course. From when you go retrospectively, we saw one of the reasons is antenatal care. From this point, I chose this topic about effect of book status on outcome of infant more than or equal 32 weeks, gestational age admit to a neonatal intensive care unit in a tertiary academic center. This is my objectives, as shown in the table. In an introduction, antenatal care should be include risk identification and screening, prevention and management of pregnant-related or concurrent disease, healthy education, And WHO recommend the antenatal care should be initiated with the first trimester of gestational age with at least 4 and optimally 8 visits during the pregnancy. In this study, was published at 2018, show the unbooked cases had lower education status, and unbooked mother had lower birth weight babies than booked mothers. And the other study published at 2020, systemic review and meta-analysis, showed the overall bold estimated indicated the odds of neonatal death among neonate from women with antenatal care were 65%, lower than those neonate from women who had no antenatal care follow-up. Recently, the study published at 2021 showed the complete adherence to guideline during first visit reduced the risk of neonatal complications. Aim of this study aim to study outcome of infant at more than or equal 32 weeks gestational admit to NICU at King Abdulaziz University Hospital, to booked comparing to those of unbooked mothers. The materials and the methods. Study design was a retrospective chart review from January 1st, 2021 to December 31st, 2021. Settings. The NICU there has a level 2 and level 3 with an NICU bed with the average number 2,800 deliveries per year with admission rate approximately 12.9%. Maternal and infant characteristics were retrieved from electronic medical record and prepared chart by trained data collectors. Population. The inclusion criteria for the study: infant born at more than or equal 32 weeks gestation and admit to NICU at King Abdulaziz during the study period. Exclusion: outborn infant. About define of booked mother and unbooked mother. Booked mother, in our hospital, the policy, booked mother, those attend at least 3 antenatal care visit, and unbooked who less than 3 or not attend at all. Sample size: all consecutive infant who met the inclusion criteria during the study period were included. Statistical analysis. The data was performed using SPSS version 2022, and the categorical variables they use chi-square test and continuous variable for independent students t-test for normal distribution, and Mann-Whitney U-test for do not follow the normal distribution. Logistic regression was cured, and adjust odds ratio and 95% of confidence interval of neonatal mortality. Study outcomes. The primary outcomes of study to see the length of stay, and the secondary outcomes at shown in other column about birth weight, gestational age, need of resuscitation, congenital anomaly, RDS, sepsis, hypoglycemia, seizure, and mortality. Ethical approval. The study was approved by the Unit of Biomedical Ethical in King Abdulaziz University Hospital. Result: 186 infants were included, approximately 30%, 57 infants were born to unbooked mothers. This, when you see here the first table about baseline demographic and prenatal characteristic, the first column about unbooked and booked, when you see the significant result here in nationality and the age of the mother, and most of mode of delivery of this infants was CS, and most of this was emergency, and comorbidities of mother was mostly diabetes and hypothyroidism. The other table showed the postnatal and delivery outcomes. When you see here, there is significant result about needs of resuscitation in unbooked mother and also jaundice and hypoglycemia. But the primary outcomes was not significant about length of stay, was median about 10 days. Another table about maternal and fetal predictors of neonatal mortality. When you see here, the maternal booked was have insignificant confidence interval, and also as mentioned before, length of stay was insignificant for both groups. Strengths and limitations. In strengths, the consecutive inclusion for all eligible infants to avoid selection bias and single data collector. And the limitations for this study was a retrospective study and the sample size of study and lack of power to detect smaller clinical significant difference. In conclusion, the study relieved suboptimal adherence to antenatal care practice among of pregnant women whose children were admitted to NICU. Also indicated poorer maternal and fetal outcome in unbooked women include emergency CS, neonatal jaundice, hypoglycemia, and the need for resuscitation. So the recommendation. Recommendation, non-national and unbooked mother should be embraced by healthcare system to accommodate them and afford appropriate antenatal and prenatal care for better outcomes. At the end, I want to thank scientific committee, my supervisor, and the NICU team.
Any questions for Dr. Saad?
Yeah, can
Yes.
I?
Yes, please.
Thanks, Dr. Saad. I have two short questions. The first is, you said those babies who are more than 32 weeks, so what is the upper gestational age limit? You didn't include full-term, definitely. And why do you think these babies, they have more jaundice than the booked ones?
Thank you for this question. Yes, as we know, more than 32 week, usually baby, if has good antenatal care, usually become good outcomes. And more than 32 weeks usually don't stay long time in NICU.
Prof. Saleh.
Yeah, your primary outcome is the length of stay, right?
Yes,
And you found no difference.
no difference, yes.
So do you consider your study as a negative study?
We have the limitations in this study about sample size was affecting the power of study and can be as a negative study, yes.
Okay. We start with the next speaker.
Thank you so much, Dr. Saad. Our next presentation will be presented by Dr. Wiam Al-Saidawi, Assistant Consultant Neonatologist at King Faisal Hospital. She completed her Saudi Fellowship program at King Faisal Specialist Hospital. She's an American NRB instructor, mentor, and she's an adjunct assistant professor at Al Faisal University. Her presentation is titled Neonatal Hypoglycemia after Antenatal Corticosteroids in Late Preterm Infants. Welcome, Dr. Wiam.
Assalamu alaikum wa rahmatullahi wa barakatuh. Special thanks for the organizing committee to give me the opportunity to present my abstract or my research about neonatal hypoglycemia after antenatal corticosteroid in late preterm infant. The hypoglycemia is the most common metabolic disturbance occurring in the neonatal period. The use of antenatal corticosteroid after 34 weeks of gestation has been controversial in the past because inconsistent data about its efficacy and very limited data on long-term safety. It is now clear that infants who are born during the late preterm period have a more neonatal complication than term infants. The ELPS trial found that administration of antenatal betamethasone to women at risk of late preterm delivery decreased the need of substantial neonatal respiratory support during the first 72 hours. Additionally, studies found that significant increase in the rate of neonatal hypoglycemia in infants exposed to antenatal steroids. The aim of the study was to determine the frequency of hypoglycemia at 24 and 72 hours after birth in late preterm infants who were exposed to antenatal steroids. Also to determine the prematurity complication in late preterm infants who were exposed to antenatal steroids. Primary outcome, the frequency of hypoglycemia in late preterm at 24 hours and 72 hours post-delivery. The secondary outcome, the development of RDS, the need of surfactant administration, and the rate of the following: NIC, IVH, PVL, ROP, and bronchopulmonary dysplasia, and neonatal sepsis. Our source of data, it was electronic in ICU database, integrated chart information system, ISIS, and patient charts. The study design, it was retrospective cohort study, including all late preterm infants between 34 weeks and 36 plus 6 weeks of gestation who were delivered in our institution between January 2016 and December 2020. The ethical approval, Research Ethics Committee, approved the study with RAC number of 2211098. Statistical analysis for the continuous variable t-test was used in the distribution was normal, and Mann-Whitney test if the distribution was skewed. Fish exact test and chi-square test were used in categorical variables, and statistical significance was confirmed at p-value less than 0.05. Our institution began to offer the antenatal corticosteroid to patients in late preterm period in February 2016, either of the dosage 24 milligram dexamethasone, 4 doses at 6 milligram to 12 hours apart, or 24 milligram of betamethasone, 2 doses of 12 milligram in 24 hours apart. All preterm included in the study 34-weeker to 36 plus 6, delivered in our institution between January 2016 and December 2020. 2 mothers who received antenatal steroid were included in our study. The infant excluded from the study part of multiple gestation, pre-gestational and gestational diabetes, chorioammonitis, and major congenital anomalies. The method, it was a methodology. Maternal data included the age and gravity, parity, and number of abortion, complication of pregnancy, antenatal steroids, the mode of delivery, and maternal infection. Neonatal data included demographic data, hypoglycemia event at 24 and 72 hours, complication of prematurity, RDS, surfactant, and surfactant administration, NIC, IVH, PVL, sepsis, and bronchopulmonary dysplasia, ROP. Neonatal hypoglycemia was defined as glucose less than 45 milligram per deciliter, 2.6 millimole within the 72 hours at birth. The result, during the 5 years study, the period, total of 192 late preterm infants were included in the study. Of this infant, 66 were exposed in the antenatal steroids group 1, and 126 cases were exposed in antenatal steroids group 2. Maternal demographic data were similar between the two groups, and we can see here in the table maternal age and gravida, para, and abortion, no significant p-value. With maternal antibiotic and maternal infection, it was not significant between the two groups. There was no statistical significance difference between the two groups at birth weight and Apgar score, and the gestational age in group 2 was higher than group 1 with a p-value 0.002. We can see it here in the table, all the same, no significant difference between them, only the gestational age was higher in the no antenatal steroids group. Neonatal hypoglycemia in the first 24 hours was higher, statistically significant in steroid group 55 versus 30% with a p-value 0.01, while 72 hours hypoglycemia events were statistically not significant between the two groups with 7.69 versus 5.5 with a p-value 0.544. This is, we can see it in table 3, where the event in the first 24 hours was significant, at 72 hours it was not significant. However, the rate of RDS was statistically lower in group 1, 23 versus 44 with a p-value 0.004. Additionally, surfactant was used more in group 2 with 1.54 versus 11 with a p-value 0.013. The other complication of prematurity, IVH, ROP, PDA, and bronchopulmonary dysplasia, neonatal sepsis, and neonatal death were similar between the two groups. This is the table 4 can show the RDS and surfactant. It was significant less in the antenatal steroids group. In this study, we found that late preterm infants who were exposed to antenatal steroid had decreased the rate of RDS and the need of surfactant use. We also found there was no significant increase in the rate of hypoglycemia in the first 24 hours at age, but did not differ between 24 and 72 hours of age. We found that antenatal steroid did not significantly affect the rate of neonatal sepsis and the complication of prematurity. In comparison to the ELPS trial, our study echoed similar result in terms of statistical significant increase in neonatal hypoglycemia and the reduction in surfactant use in steroid group. Also similar to ALPS trial, our study showed similar result regarding the rate of peripartum maternal and neonatal infection, where there were no statistical significant difference between the two groups. The strength of our study, the strength of the study, excellent control, and well-grounded positive finding that can be generalized and considered in the clinical practice. To the best of our knowledge, this is the first study, I think, done in Saudi Arabia. The limitation of the study, it was retrospective cohort study with limited number of patients. A well-designed multi-center prospective trial with adequate sample size is recommended. The conclusion, we concluded that administration of antenatal corticosteroid to pregnant women at risk of late preterm delivery significantly increased the risk of hypoglycemia in the first 24 hours. However, the hypoglycemia event in the 72 hours was resolved. Also, there was decrease in the rate of RDS and the need of surfactant therapy. This is my references, and thank you for listening.
Thank you so much, Dr. Awiyam. Any questions regarding this presentation? Dr. Sajjad.
Yeah, thank you very much. It was an excellent study. So what is the mechanism of this hypoglycemia which results secondary to antenatal steroids?
The mechanism not well known. There is two mechanisms, or from the antenatal late steroids, the antenatal steroid for the mother can cause hyperglycemia. This can cause hyperinsulinism for the baby, so inducing hypoglycemia in the first 24 hours, and it is transient and resolved. Also, there is another theory, maybe adrenal suppression from the steroids.
Thank you.
Thank you, Dr. Awiyam. Do you think your study can have some implication to our current practice?
Yes, it will help, yeah.
In what way?
In reducing the RDS, the length of stay, the use of surfactant therapy, mechanical ventilation.
Would you do anything to prevent hypoglycemia in those infants?
Monitoring them as at risk. If we know this mother, she is taking antenatal steroid late preterm, we'll monitor them for hypoglycemia. If they need admission, we'll admit them for this.
Thank you so much for your excellent presentation.
Thank you, Doctor.
We'll move on to the third presentation of the day. Dr. Saad.
The third presentation will be by Ms. Fita Peter. She's going to talk about implementation of early CPAP initiation in the delivery room for preterm neonate, gestational age between 28 to 32, decreased the mortality rate by reducing the need for intubation.
What will be presented?
Ms. Fita is a hospital management neonatal nurse specialist in RB instructor and also stable instructor, King Saud Medical City. Thank you.
Good afternoon. Thank you, Dr. Said, for the introduction. And first of all, I would like to thank the scientific committee for giving the opportunity to share the experience. I'm going to present a quality improvement project which was done in our NICU King Saud Medical City during the pandemic from April 2021 till March 2022 for 12 months. The project title, Implementation of Early CPAP Initiation in the Delivery Room. Babies who are born between 28 to 32 weeks of gestation and decrease the mortality rate by reducing the need for intubation. To begin, as we all know, RDS is one of the most frequent causes of respiratory failure and death among preterm infants. And the standard treatments were invasive mechanical ventilation and surfactant administration. Current evidence-based studies demonstrated the initiation of CPAP significantly reduced the need of intubation, mechanical ventilation, and exogenous surfactant. So what is the reason for starting this project? So in our NICU, CPAP was not previously initiated, especially for the preterm babies less than 32 weeks, due to many challenges. The main reason for starting this project, we had, I was brought to attention to review the CPG protocols for CPAP. So that time we dig to the data from April 2020, March 2021. The babies who are born between 28 to 32 weeks of gestation, 0% of babies initiated CPAP in the delivery room. And out of that, 97 babies intubated and transferred to NICU. And 3 babies started on nasal cannula. Once they reached the NICU, they were initiated CPAP in the NICU. So we sit together to identify the problems. We did brainstorming. The first and foremost, the problem was if any baby delivered to less than 32 weeks, immediately intubation was done. The main thing is, the first major challenge was the supply issue. We don't have equipment, new puff or TP's resuscitator in the delivery room, and also the consumables related to that. The second thing, because there was no supplies there, so the staffs lack knowledge regarding the CPAP initiation in the delivery room, and also there was no clear criteria when to initiate the CPAP in the delivery room. And as the universal problem was the staffing, especially we send only one physician and one nurse to attend the high-risk deliveries because of lack of shortage of RT and also the nurses. And there were no documentation to monitor the vital signs, to monitor the compliance in the delivery room. Once they resuscitated, they will bring the patient to NICU. After that, they will start doing the documentation in their nurses' notes. Nurses and physicians are the same. So with all these challenges, we plan to start this project. Our objective was to increase the use of CPAP as a primary mode of respiratory support in the delivery room, to reduce the need for intubation. So we selected the first thing, we selected our criteria. We selected the age group between 28 to 32 weeks. The baseline also was 28 to 32 weeks. We found 165 babies. So the first criteria was a good respiratory effort, heart rate more than 100, no known contraindications for CPAP. So this is the reference from the NRP, as we all know. And we initiated because we had a very big challenges, so we have taken actions before our implementation. The first thing, we had a clear criteria, and we put our CPG guidelines, and webinar was conducted by our physician to all the physicians, and also we formulated the form to monitor the vital signs in the delivery room while doing the resuscitation. And we provided the radiant warmer, which was built-in TPs resuscitated to all the delivery rooms, including the labor room and OR. And after that, we tried to get a CPAP supply. It was very hard, and by the hospital administration, they have tried to get it through the direct purchase. Then we started providing at the same time NICU staff training for the nurses, for the physicians, and also doctors how to use the TPs resuscitator in the delivery room. So with all these challenges, we moved. We started a CPAP initiation campaign, and we started the project on 1st April 2021. And the major challenge was actually once we start implementing the project, we started doing the team with one physician, one nurse, and one RT to attend all the high-risk deliveries with all the shortages, and a time frame for 12 months, as I mentioned to you. So the implementation phase, during the implementation, so after we started, within the first 3 months, we went through many restraining forces. The first and foremost, some physicians were really hesitant to initiate CPAP. The major challenge was the transportation issue, because they have to, our transportation issue means a hospital from the delivery room to the NICU. To transfer a patient, it will take almost 15 to 20 minutes because it's a different hospital. So this was one of the issues. So they were comfortable to intubate the baby and transfer the baby to NICU, then to extubate after 5 hours or 6 hours. This was our practice. So some physicians were still hesitant and reluctant to initiate CPAP. So what we did, we tried to monitor, we informed the nursing staff to monitor, to put the criteria in the delivery room, and if any baby is born newborn. They will do the initial assessment. If the baby fit with the criteria, the nurse will show it to the physician that this patient is for CPAP initiation. So that's how we start motivating the physicians to initiate the CPAP in the delivery room. Sometimes they were very reluctant, so this every day on daily basis we used to monitor the CPR form, and if the patient fit the criteria and still they intubated the patient, the doctors were assigned to follow up to do individual counseling with the physicians. The next major challenge during the implementation phase was the limited medical supplies. That was also solved through the hospital administration. And as we always talk about the staff shortage, one day the nurses, all of them, they came to my office and they said we were not going to continue the project because it is very hard to convince the physician. The second thing, shortage, we cannot do the documentation, we cannot monitor the patient because only one nurse is she has to assist with the physician. So we sit and we try to talk to the nurses, convince the nurses, explaining about the outcome of this project. And then we try to assign 2 nurses, one to document and one to assist, and at the same time we assign the RTs also to participate in this, attend the delivery during the, especially for this high risk deliveries. So by then we try to solve the issue, we try to convince the physician, convince the nurses to move on this project, and also they were resistant to document because before there was no documentation. So later, with all this explanation and meetings, and they were complying with all the instructions. So with this, we found almost, because it was a COVID time, and our hospital is one of the referral hospital, so we had high number of referral cases at that time. So as you can see in the baseline, it was only 165 patients, and during our project for 12 months, total number of preterm babies admitted between 28 to 32 weeks, it's almost 227 babies. So with all this challenge, out of this 227 babies, 108 babies were initiated CPAP because they met the criteria, and 119 were intubated and transferred to NIC because they did not meet the criteria. And some of the babies were, even though they met the criteria, but still in the initial phase they were intubated. So what was the outcome? The major objective was to increase the CPAP rate and to decrease the intubation rate. So as you can see in the graph, this is for the babies who are initiated CPAP, almost 108 babies. As you can see, from 0% it increased to 69 in the first quarter. Then we tried to maintain the 100% compliance. And as you can see, the intubation rate, it reduced to 31 and 0. After that, it was now continuing this. So this graph shows for the overall babies. So the first graph, it was only babies who are initiated CPAP. This baby is initiated CPAP plus intubated. So total 27 babies. You can see the intubation rate is declining, and CPAP rate was increasing to 67, 91, 83.
Ms. Vita, 1 minute to go.
Sure. So 65%. So these are the major outcomes. This was our primary outcomes, and after that we compare with the mortality rate. We found the mortality rate reduced for the CPAP babies from 17 to 0%, and overall the mortality rate reduced from 17 to 7%. Then we tried to measure the secondary outcomes, ROP, CLD, and IVH grade 3 and 4, and out of the CPAP babies we found there was 0% of severe ROP, CLD, IVH, and also the NIC. And this is overall outcome for the overall babies, around 227 babies. ROP rate was decreased and IVH is quietly decreased, CLD not significantly reduced, but NIC rate was reduced because I cannot say NIC rate is because of this project, because we had another project for exclusive EBM, so that can really reduce the NIC rate. So just we were the winner for this project, International Hospital Federation for Patient Safety and Quality, and this was awarded in this month, 10th November in Dubai. So I would like to conclude the major part the major role was played by the nurses. So mainly we talk about the universal, why do nurses resist changes? So always, if you want the project to be done and if you want to maintain a continuous quality improvement in the patient care, we need the full cooperation from the nurses. So nursing shortage is always, if you ask anyone, they will say 99.9%, they will say, talk about nursing shortage, it is universal. So that is not the end. Nurse leaders play a very significant role in continuous quality improvement in patient care. So that we need to think about. I would like to conclude and thank my team.
Thank you very much. Thank you. Any questions, please?
There is one question. If you can
Okay,
allow me.
please.
Thank you very much. I think it was a very good presentation by the nursing colleagues. My question is, what exact CPAP machine and CPAP interface were you using? And secondly, how were you excluding coronary atresia before starting CPAP?
Sorry, the first question, sorry? It was the CPAP machine. Okay, sorry, we were using the Tradiant warmer, which is built in the TP's resuscitator. So it is a resuscitator, which you can see built-in TP's resuscitator. By nasal? Yeah, by nasal, with using the prongs. Prongs or mask, yes. Mask, nasal.
What was the second question?
The judge?
Yeah, second was, how were you excluding coronary atresia before starting CPAP? She said one of the exclusion criteria was coronary atresia. So how did she actually exclude
How did
that?
you exclude coronary atresia in your population?
Yeah, sure. The thing is, actually, this was our criteria, but during our implementation process, we did not come across the case. As we all know, this coronary atresia, you cannot start the nasal prongs. Sometimes we have supplies with the prongs or mask. So that is the main reason we put exclusion criteria for the CPAP.
Thank you.
Thank you.
دكتور تفضل.
Thank you for this presentation. I just ask, any of this group received LISA before you start CPAP, or all no Cervanta given at all?
What we did, when
they give less invasive surfactant administration, or all CPAP from the start without giving any Cervanta?
Without giving surfactant.
All CPAP?
Yes. Some babies need intubation after that, so we intubated and given surfactant.
Yes, thank you.
Thank you so much. Another question? Thank you so much, Vita. Thank you. We'll move on to the fourth presentation of our abstract presentation session. This next presentation will be presented by Muhammad Bahadur, medical student in the National Guard Hospital of Jeddah. And he will be presenting today on survival and predictors of mortality of congenital diaphragmatic hernia in tertiary care center in Saudi Arabia. Welcome, Dr. Muhammad.
This one.
This one?
No. نزلت الثاني خلاص. Can I use the mouse here? Yes, okay. Okay. Okay, assalamu alaikum everyone. Good evening. I am Mohammed Bahadir, a 6-year medical student at King Saud bin Abdulaziz University at Jeddah. I'm very happy to be here today, and I would like to thank the conference organizing and scientific committee for inviting me and to present and giving me this opportunity. I believe this research will help in the practice and will also benefit our little precious newborns. So, this research under the title of Survival and Predictors of Mortality of Congenital Diaphragmatic Hernia in Newborns at a tertiary care hospital in Jeddah, King Abdulaziz Medical City, National Guard. This research was supervised by Dr. Mohammed Al-Hindi, and also I would like to thank Dr. Mansour Al-Qurashi, the Dean of our college, and Dr. Ahmed Mustafa, and of course Dr. Jabara for their continuous support and teaching. This is the outline. Gonna start with the background. Why is this study significant? Gonna talk about the aim, methods, results, and discussion along with each other, and end up with a conclusion and recommendations. So, congenital diaphragmatic hernia is a rare conditional disease that approximately happen at a rate of 0.03 worldwide. This is a percent. We found a couple of studies. We have two studies whose estimated prevalence. This one is an international European surveillance for congenital diaphragmatic hernia. 31 studies with an estimation of 1 per 4,347 live birth. Also, we have here King Fahd Hospital in Al-Baha did a study, and you can see it's 1 per 2,320. This was happening 11 years from 1981 to 1982. We will talk about the difference of the rate later. As you can see, here's the mortality rate. Internationally and nationally, we have the kids and patient database from USA, 51%, and you can see that all the rates in the local are similar to one in the international. As you can see, the incidence was low or rare. However, the mortality is a great significance with such a disease. Thus, some studies did tools that can predict mortality. These are some of them. I'm not gonna mention them all. There are antenatal and postnatal. We have lung head ratio by ultrasound. This is an antenatal tool to predict mortality. For example, if it's more than 1, it's a better prognosis. We have the CDH study group, probability of survival. This is also a score that can be calculated with, for example, low birth weight, low Apgar, and etc. We have Bindle score, and SNAP2, of course, we mostly familiar with. And we have the defect size. More on that later. So why is our study significant? Up to our knowledge, this is the first study to use or study the predictors of mortality here in Saudi Arabia. We calculated the prevalence and mortality to provide clinicians with a general estimate, not only the clinicians, but also for the parents. We want to establish a benchmark scores that can predict mortality and survival. Why? To help allocate resources. The aim is to estimate survival, evaluate predictors with a statistical analysis. So briefly, the methods is a retrospective cohort study, included all newborns without exclusion from 2000 to 2021. That's a sum of 21 years in the King Abdulaziz Medical City, Department of Pediatrics, Division of Neonatology. So we compared, let's see here, we compared the prevalence, demographics, and clinical characteristics of the neonate and the mother between infants who survived and died. And we use C-statistic to evaluate those predictor scores. More on that later. We need to explain something about the C-statistics when it comes. So, inclusion criteria, all newborns, exclusion, no exclusion. By default, this is non-probability consecutive sampling technique. The data collected from physical files and electronic files. In our center, we use Biscare. This is the data collection done by students, mother, infants. We have the prenatal, and we have the postnatal, as you can see, from first hour of life to the 24, because some scores need that. For example, SNAP2. Okay, general characteristics of the neonates. We ended up with 45 patients in the 21 years. 80% of them were inborn and 20% were outborn. Why is that important? Because we want to only estimate the prevalence or incidence in our center. So we excluded the outborn from here. But the other outcomes, mortality and the clinical outcomes, we included the outborn. Mean birth weight, as you can see, it's similar between those survived and died. Mean gestational age also. Among those who died, 19 of them died preoperatively, and 4 of them died postoperatively. So we estimated the prevalence. So among the 21 years, we had 66,844 total birth. MashaAllah, tabarakallah. So we estimated only the newborns. It's 1 per 1,856. And the mortality rate was similar to the others, 51.1. Now let's compare it to the literature. When you compare it to the international, as you can see, we're almost double the incidence here in Saudi Arabia. And you can see we are similar to the one done in Al-Baha, 1 per 2,000, we're almost the same. Why is that? We can discuss it after the presentation, but we think that maybe consanguinity is a problem. And later for the recommendation to estimate that. Okay, on mortality, we have a similar mortality to the other studies internationally and locally. Let's start with the maternal characteristics. So when you look at this table, we have death, alive, and we have the p-value to estimate if there is significance. So there is no significant difference between those who died and alive in the maternal characteristic, not the age, not the body mass index, not the presence of comorbidity, delivery mode, delivery complications. And we go with the gravidity, priority, abortion, all been estimated, and there is no significant difference at time of the diagnosis. But we have a significant difference in the inborn and outborn. As you can see, we have 9 outborns, only 1 of them died, and 8 survived. However, when you see the inborn 36, we have 22 of them died. Why is that? After discussion with Dr. Muhammad al-Hindi, Dr. Muhammad al-Qurashi, we, as a theory, all those who transfer to us might be discovered only incidentally, mild cases, or only referred for us for repair. So maybe that a cause, but further studies or further analysis need to be done. Now with the neonatal characteristic, we have general characteristic labs and clinical. No significant difference regarding the gender, gestational age, associated anomaly, echo, whether it's prenatal or postnatally, and ultrasound. ECMO, MRI. But however, when we come to the laboratory findings, such as PF ratio, Apgar score, this is a clinical one, when we have the low pH, urine output, they're all significant. But this is by default, we expected that to be worse and in those who died. This is the column for newborns who died. It's going to be worse, of course, with those who died. However, we benefited from these outcomes for later to estimate the tools or the score. Remember, we just mentioned them. For example, we have SNAP2. We use this score by picking the worst of the variable. For example, mean blood pressure, low temperature, and etc. Now let's go and see. How did we see if these scores are significant? We use something or a tool called C-statistics. This one we picked because it was used.
Dr. Muhammad, 1 minute to go.
Okay, this one is used in the previous studies. So I'll give you an example for it. For example, lung head ratio. Among those who died, it was 0.89. Among those who lived, it's 1.5. What's the meaning of C-statistics here? 0.84. It means that 48% chance of what? Survival if the score is 1.5 or above. We didn't find significant difference in stomach herniation, liver herniation. However, we found in SNAP2, CDH study group probability, and Brindle score. And you can compare it also with the other studies. We compare them, and we are fairly similar with them. Strength, this is the first study to use a predictor of mortality here in Saudi Arabia. We are one of the few studies that calculated prevalence and mortality. The sample size was low, however, we managed, alhamdulillah, to get a statistical significance for such outcomes. It's and due to the retrospective cohort, missing data was happening. For example, the liver herniation, a lot of them, and consanguinity also, was missing in a lot of patients. Our prevalence is high, however, we showed similar mortality to literature. We established and validated benchmark score. This is the beginning. Score that can predict survival to help allocate resources. We recommend and suggest a national multicentric registry for CDH. Why? To have a more accurate estimate of the validated predictor tools for the future. An example for consanguinity, for example, and the other tools. This is my beloved college, thank you. And these are the references. You can scan the reference and you can take the slides for further teaching or something. Thank you very much.
يعطيك العافية. شكرا جزيلا دكتور محمد، ما شاء الله على الحماس. انت تقدر تقنع اي احد في الديتا حقتك ما شاء الله.
تعليم دكتور منصور.
طيب I have a question. Why did you say ما شاء الله تبارك الله على عدد الولادات اللي عندكم؟
الولادات طبعا نعمة. فحتى لو كانت 3 حقول ما شاء الله تبارك الله. الحمد لله هذه نعمة، والله يعين اللي ولدوا ويصبرهم اللي ولدوا بCDH.
Any questions? We need someone else, not just you, Dr. Sajjad. We'll wait for another one. Doctor, I'll give you the next one.
Thank you, Dr. Muhammad, for this nice presentation. I want to ask you about any study related to the time of surgery, early or late surgery, to the outcome of mortality for this patient.
Is it working? Can you yell the beginning of the questions? I'm sorry.
There is a relation between early and late surgery to outcome of mortality. Is it different from late and early surgery?
Okay. First of all, I'm a medical student, but I can answer with what I know. In the literature, this is what I know. When we studied and we thought about the discussion, mostly died preoperatively because of the nature of the disease, and most of them. And that's the only explanation I can have. But if any one of you expert about the knowledge, let's have a discussion about why would.
I don't think you looked into that, huh? دكتور.
نعم، عندي question لك يا دكتور. العود كم? Is there any antenatal intervention done for those patients? You are talking about 50 patients. Any antenatal done intervention?
Can you bring the slides back, please? So, as an antenatal intervention, we didn't measure that, but we had, for example, ultrasound antenatally. Okay, let's see here, maternal characteristics. So we only included antenatal care if there is follow-ups, and mostly, not mostly, follow-ups were 36. Let's see here. Echo done prenatally, but 18 of them missing. That's why we need a registry. Such a disease is not documented well in Saudi Arabia, especially it's a rare disease. A lot of studies done here in Saudi Arabia. This is maybe a starting point to be aware of this disease with such high mortality.
طيب يعطيك العافية دكتور محمد. Thank you so much. We'll move on to the next presentation. You will present.
The last, not least speaker, Dr. Wid Fatani, senior medical student, King Saud bin Abdul Aziz University for Medical Health Sciences. She's going to talk about the accuracy of umbilical cord total blood count in detecting neonatal thrombocytopenia. Go ahead.
So good evening, good afternoon, everyone. My name is Wid Fatani. I'm a senior medical student from King Saud bin Abdul Aziz in Jeddah. First, I'd like to thank the Saudi Neonatology Society for this opportunity. And I'll be presenting our study entitled The Accuracy of Umbilical Cord CBC in Detecting Early Neonatal Thrombocytopenia. So a bit of background first. So early neonatal thrombocytopenia, which as we know is a platelet count of less than 150 in the first 3 days of life, is one of the feared hematological disorders due to its complications, such as perinatal intracranial hemorrhage. Umbilical cord CBC is a routine screening tool used for detecting different hematological abnormalities, including NTCP, in some hospitals. A follow-up infant CBC is done to confirm the diagnosis, subjecting neonates to iatrogenic blood loss and possibly wasting resources. Previous studies were conducted to assess the value of the cord CBC in predicting sepsis, screening for hematological disorders, such as in preterm infants. However, up to our knowledge, no other studies were done to assess the accuracy, as in sensitivity and specificity, of umbilical cord CBC, specifically in diagnosing neonatal thrombocytopenia in both preterm and term infants. So this study aims to determine the accuracy of umbilical cord CBC to diagnose thrombocytopenia. Specific objectives were to measure sensitivities and specificity, as well as to measure the prevalence of neonatal thrombocytopenia in King Abdulaziz Medical City in Jeddah. So we used a cross-sectional study design with a matched control group. The study was conducted in the obstetrics and neonatology department in KMC. The study period was between May 2016 and May 2019. Our inclusion criteria was all live births in KMC between May 2016 and May 2019, with a routine umbilical cord CBC taken and intact. We selected controls of healthy newborns with intact cord and infant CBC, randomly in a 1:2 ratio, matched for year of birth, gender, and gestational age. We excluded, however, neonates with major congenital anomalies and chromosomal abnormalities, neonates with antenatal diagnosis of immune and non-immune hydrops fetalis. So we compared the cord platelet count to the gold standard infant CBC within 72 hours. We measured the prevalence, calculated the sensitivity, specificity, negative predictive value, and positive predictive value as per their definitions. So we found that out of 10,936 births in the study period, we identified 111 neonates with thrombocytopenia. We excluded those who did not meet our inclusion criteria, and we ended up with 40 thrombocytopenic neonates with intact cord CBC. We matched them to 80 healthy neonates, also with intact cord and infant blood samples. Our estimated prevalence was 10 per 1,000 live births, or 1.015%. We compared the characteristics of both the control group and the cases group. So we found statistical significant difference in the antenatal care, which was less in groups with thrombocytopenia. Also, there were higher rates of intrauterine growth restrictions and oligohydramnios. For the neonatal characteristic, we found that neonates with thrombocytopenia had more rates of neonatal sepsis, admissions to an ICU, platelet transfusions, as well as a higher mortality rate. For the lab parameters, apart from obviously platelet counts, there were no significant difference between the two groups. This is the classic 2x2 table we used to measure sensitivity and specificity. We used the confidence interval of 95% and estimated the sensitivity of 62.5%, specificity of 97.5%, a positive predictive value of 20.4%, and a negative predictive value of 99.61%. So what we found is the prevalence in our center was consistent with the local studies as well as international studies, which all estimated the prevalence between 1 and 5%. As expected, no antenatal care, intrauterine growth restriction, oligohydramnios are all risk factors affecting fetal well-being and making them more likely to have early neonatal thrombocytopenia. Also, neonates with NTCP were more likely to be admitted to an ICU, develop sepsis, receive platelet transfusions, and had higher mortality, as I mentioned, which highlights the importance of screening and early detection of neonatal thrombocytopenia. The high specificity and low sensitivity of this test aids physician to discharge patient with normal platelet count with high confidence without the need to repeat the CBC. However, a positive cord result cannot be fully relied on to diagnose the disease, and the follow-up is necessary for confirmation. Considering the low prevalence of neonatal thrombocytopenia, high negative predictive value means cord CBC can be safely used to reassure parents of babies with negative results, hence supporting our current practice of not repeating CBC of those healthy babies. However, the poor positive predictive value indicates the need for a thorough clinical history and examination and a follow-up CBC to confirm that diagnosis. The strength of our study are that we're one of the few to measure the local prevalence. Our study was adjusted for year of birth, gender, and gestational age, and up to our knowledge, it's the first to assess the accuracy. Limitations were due to the nature of the study. Missing data could not be controlled. The results only applies for early neonatal thrombocytopenia, and we had a relatively small sample size. In conclusion, neonatal thrombocytopenia is a rare but serious condition in Saudi Arabia. Thus, screening and early detection are recommended. Also, a high index of suspicion is essential for interpreting umbilical cord CBC platelet counts, especially when the results are positive. Thank you very much. These are my references.
Thank you very much, Dr. Awid, for this nice presentation. Now, it's open for a question. Prof. Saleh Al-Ayyan.
Thank you very much. You mentioned that the positive predictive value is around 50 or something.
We can go back to it. Actually, the positive predictive value and the negative.
Listen to my question.
Sorry. Yes, go ahead, Doctor.
Yeah, I mean, how do you explain this?
They are.
What's the number of your positive predictive value?
It's 20%.
20?
20. It doesn't. I'm sorry, it's not shown on the screen, but it's 20%.
That's
because
very, very low, huh?
Because positive predictive value and negative predictive value are both affected by the prevalence. Since the disease is not that prevalent, it lowers the positive predictive value. The answer to your question.
Okay.
Any more question? Yes, please.
So, thank you for your presentation, very nice.
No.
So, did you make sure whether the sample was arterial or venous?
It was venous. Sorry?
Umbilical artery or vein sample?
I'm pretty sure it was venous.
So how does this reflect the baby?
I'm not really sure, to be honest. Can you?
Because the venous one comes from the mother, right? From the placenta.
Yes. I'm not really sure it was arterial or venous.
Thank you.
One more questions, please. Yes.
Yes.
Go ahead. Okay.
Professor Jad?
Yeah, it's not a question from the speaker, but just a small comment that the quality of presentation by all the speakers was very good. And for the level of their training, they presented very well. And I think they all should be congratulated for their efforts. Thank you.
Thank you, Prof. Sajjad, for this nice comment. Actually, you are faster than me. I'm going to say the same comments. Actually, we enjoy 5 talks. Each one, it's addresses a very important subject. Thank you very much for the speaker and also for the delegate. Maybe now Prof. Prof. Khalid Al-Falih has a talk, and then I hope that he will
Prof. Saad, while they are finding the result, Can we start our closing ceremony? We will announce the result of the referendum.
Actually, we have the result.
الريزلت already.
Where are you? وين هو الدكتور سعد؟ وين الدكتور عبد الحكيم؟
لا موجود عندك تفضل.
We would like to invite you and Dr. Nimri to the
طيب
podium.
go ahead. يلا يا عبد الرحمن تعال.
To present the awards. And I think I would like to take this opportunity and to thank the Saudi Unitology Society for keeping this tradition of research abstract presentation a regular occurring in every annual meeting of the SNS. And I do hope that in the future we will be able, inshallah, to encourage more and more research in the country. We really highly need more and more of high quality research, epidemiological studies in Saudi Arabia to guide our practice and policy making. Dr. Saad or Prof. Saad was much more generous than I am. So we took the average of the 2 marks that we marked the presentations during the presentation, and we will start by Prof. Nimri. Are you ready? You're ready. Okay. We will start with the 3rd award that was given to Dr. Muhammad Bahadur for his presentation. صوروا Third, yes. ما شاء الله. Make sure I'm in the picture, please. Thank you so much. يعطيك العافية. توفيق إن شاء الله. Our second award for today is given to Dr. Awad Fatani for her excellent presentation. A certificate from the SNS for her award and a 3,000 riyal. Now comes to our winner of 2022 SNS abstract presentation that was given to Dr. Wiam Al-Saidawi from King Faisal Hospital.
مبروك يا وئام. You win 5,000 riyal from the Saudi Neonatal Society. قلنا لهم يحطوا زيادة صفر قالوا ما في ممنوع. مبروك يا وئام. بالتوفيق. يعطيك العافية. Also we have some other people to be يعني appreciated, and we'll start with the podium. We have Dr. Khalid Al-Falih. Professor Khalid Al-Falih is one of the people who are quite near to the society. الله يحييك يا مرحبا. يا بروفيسور. الله يحييك يطول عمرك. مع صورهم ها؟ لا ما في. البروفيسور صالح العليان he was the chairman of the society at one stage, and we to appreciate his work with the society for years with a lot of contribution. باخذ واحدة مع ابوي يزيد. تفضل. لا ليش لا نشيله لك يا اخي والله تامر والله يا ابوي يزيد. تسلموا شكرا الله يحفظك. شكرا. صخر الحين يجي. الله يحفظكم بارك الله فيكم. طيب بقية الزملاء اللي شاركوا في البحث العلمي نحب أن نعطيهم شهادات للشكر ونتمنى لهم إن شاء الله التوفيق المرة الجاية. باقي عندنا فيتا بيتر. وكذلك سعد العامري أو العامر. تفضل. Yeah, you need to be in the middle. في regulation for things. It's not.
Vita. One more. Yes, tell me. Yeah.
سعد تفضل يا عاد سعد.
المري مش العامري.
المري هو الكاتبين. المري ها ونعم حياك الله.
شكرا لمشاركتك.
موفق ان شاء الله. السنة الجاية تجيب لنا another two research.
ان شاء الله.
لازم تفوز. الله يحييك طول عمرك. هلا. تفضل. هنا قاعة الملك فيصل والاستاذ سلمان. الشكر موصول لقاعة الملك فيصل والتجهيزات الجميلة اللي موجودة فيها، ونشكر الأستاذ سلمان العتيق، ونحب الحقيقة أن نشكرهم. يعني كانوا حريصين أنه يعني يكون البرنامج إن شاء الله في أفضل حالاته. الله يحييكم، الله يحفظكم، مشكورين، الله يحفظك يا هلا أبو فارس. الله يحييك. والأستاذ عبد الله الحميدي. حياك الله عبد الله، الله يطول عمرك ودعم فيكم، موفقين ان شاء الله. ان شاء الله اذا زرتوهم السنه القادمه حيكون عندهم رينوفيشن، حتشوفوا شيء جديد، يعني شيء يعني يجعلكم يعني تنبسطوا اكثر. هي
سكرين تكون موجوده من اول يوم.
وحبيبنا الاستاذ والدكتور مجيد سعيدان، تفضل الله يحفظك.
He was my teacher in 1993.
حياك الله الله يحييك طول عمرك. مرحبا بك. الله يحفظك. نأتي فقرة الأخوة المشاركين من الشركات الراعية، ونبدأ بالراعي الذهبي للمؤتمر شركة أسترازينيكا. تفضلوا يا جماعة. حقيقة they commit themselves from early on they continue to commit themselves for the activity of the society, supporting the educational like you know. هلا حسام حياك الله يا مرحبا. افتح لهم اياه عشان يصورون. هذول الذهب هذول اخبار الذهب.
الله يسلمك.
دعواتنا لكم بالتوفيق. تسويق. شهادة كمان بعد. استرازينيكا.
خليها مع
وهذه
وهذه تكنو اوربت تفضلوا. مهندس حازم، مهندس فادي، حياكم الله. They are committed يعني with us for the last few years and we will like to continue with this type of. الله يحفظكم. شكرا. الله يحفظكم بارك الله فيكم. بالتوفيق. ايش المناورات هذه؟ ايش المناورات يا ممري؟ الله ما شاء الله عليك. شكرا. نبغى ابوت نستلا تفضلوا. بعدين نسلة نضيف نيوتريشن ولا ما يحتاج؟ يلا ما ايش اسمهم دول؟ لا بعدهم ايش اسمهم؟ ورديسة. اهلا وسهلا الله يحفظكم. موفقين ان شاء الله. أورديسا هم بليمير ها؟ اوكي.
نتوقع منهم السنه الجايه اكثر ان شاء الله.
هلا الله يحفظك يا هلا حياك. هلا يا هلا. يعطيك العافيه ابو مروان. شكرا. شركة الجيل ما في شيء ثاني موجود هنا. الأخوة بمناسبة بمناسبة توقيع الاتفاقية مع جمعية الرضاعة الطبيعية ودنا أن نكرمهم كذلك بينكم الدكتورة فاطمة الجعوان تفضلوا. والحقيقة ودنا نكرم كل الأخوة المشاركين في الوركشوب لكن الحقيقة ما شاء الله عليهم لا زالوا يعني يعملون بجد واجتهاد ويعلمون فلذلك الظاهر نحن بنروح من يريد أن يحضر تكريمهم فليأتينا هناك أما نحن فذاهبون حتى نكرمهم يعني في موقعهم فالله يحفظهم. جزاهم الله خير وأنا حريصين الحقيقة وأنا متأكد الأخوة اللي شاركوا في الوركشوب استفادوا كثيرا.
دكتورة فاطمة شكرا من الأعمال.
دكتورة فاطمة الجعوان بالتوفيق يا دكتورة إن شاء الله فاتحة خير إن شاء الله. الله يحفظكم. طيب وانا اجعل الكلمه الاخيره لرئيس الجمعيه. تفضل.
ثاني مش انا قلت لكم مرة. طيب السلام عليكم ورحمه الله وبركاته. الحمد لله على التمام، الحمد لله على الكمال. بالامس وقفت هنا وتتذكروا اول شيء قلته: اللهم لا سهل الا ما جعلته سهلا وانت تجعل الحزن اذا شئت سهلا. فالحمد لله على تسهيل هذا المؤتمر رقم 21. A lot of obstacles، لكنكم من أجل عينيكم غنينا، ومن أجل عينيكم أوجدنا لكم أحسن المطربين، فغنوا لكم طوال هذه الثلاث لأنكم تستاهلوا. فوجودكم هو نور المؤتمر، تواجدكم هو نجاح المؤتمر إلى هذه الساعة. أشكركم من أعماق قلبي. الشكر موصول لمدير المؤتمر دكتور عبد الحكيم قطان واللجنة المنظمة وجميع الأعضاء. الشكر موصول لأبو مروان بروفيسور سعد السعدي وهو في اللجنة العلمية. أحضر لكم ماتيريال كلها clinical practice، وmaybe this is the first time to bring our breast milk to bring our breastfeeding in the conference، وإن شاء الله will continue. فشاكر لكم من كل قلبي، وأتمنى السنة القادمة مع البورد الجديد، لأن يمكن هذا آخر مؤتمر لهذا البورد. امبارح شكرت كل الأفراد وقلت لهم ما عندي شيء غير إني أدعي لكم. أقولها ولا بلا؟
انتوا عارفين ايش حيقول لكم، بس اسكت.
فاستودعكم الله، واتمنى ان اشوفكم في 2023 باذن الله تعالى.
تبغى تدعيهم نفس الدعوه؟ شغلتنا انت.
شكرا جزيلا سخر.
شكرا.
مبروك.
ما قصرت.
ما قصرت. يعطيك العافيه محمد.
بارك الله فيك. ايوه ناخذ الشهادات. اليو اس بي حقي باخذه. ايش رايك كذا؟ طلع. الله يكرمك، طول لي عمرك، بس نحن عشان ايش؟ بس انا خايف اطلعه ويصير مصيبه يعني. لا الحين يصير له ايش يقول هذا ديفايس از كرنتلي ان يوز، فكيف نسكره هذا؟ او انا اقصد حقي هذا. في طريقه ثانيه للتسكير، وريني اياها عشان ايش؟ شايف سكرها من هنا صح؟ بعدين تيجي مره ثانيه تسكر. حلو. شكرا، الله يحفظك. تسلم. الله يحفظك. الله يحفظك.